Thank you, Steve. And thank you for the opportunity to speak here again this year. I very much appreciate it. I'd just like to take a minute to dedicate this lecture to a real legend, Maya Angelou, who you may know sadly died yesterday at the age of 86. And I think we talk a lot about successful aging as geriatricians, and we tend to measure the things that we know how to measure, things like gait speed and muscle strength and aerobic capacity, cognition, etc. But we tend to forget about the things that probably truly make up successful aging, as Maya says, things like passion, compassion, humor, and even some style. So I'd just like to dedicate this lecture to a very legendary woman. So I am a geriatrician, as Steve said, and I think we don't get the chance to see a lot of people who have successfully aged because only a few people meet that definition. So I'd just like to present somebody who is quite typical of perhaps of some of the patients that we do see. So this is an 84-year-old gentleman, never married, worked his entire life in the hospitality industry as a chef and restaurateur. Very heavy alcohol intake, as most chefs will admit to, although it never seemed to impact on his social life or his career in any way. Quite a complex medical history, including polio as a young child, chronic atrial fibrillation, surgical repair of a bowel obstruction, 2 strokes, aortic valve replacement, cardiac arrest with a pacemaker, prostate disease surgery, bladder cancer, inguinal and femoral hernias, clinical depression, osteoarthritis, and rotator cuff tendonitis. So typical geriatric patient, and perhaps you'd like to pick him out of this lineup. This is Mr. Do you know which one he is? This is Mr. Ray Moon, who I had the pleasure of meeting last year. He is the world's oldest competitive bodybuilder at age 84. He didn't start training until he was 76, which he did, in fact, because of his clinical depression that he had developed in response to many of his illnesses. And he is the 4-time Australian over 70 champion. Some of you who are not up on your anatomy may realize that this is not a new muscle here, but this is in fact his pacemaker right here. We had the pleasure of testing Ray in our laboratory, and one of the things we did was a DEXA scan, and he was out of his training season, a little bit liberal with his diet at the time we tested him, so he was a bit apologetic about his body fat of 11.8%, which, as you can see, is at the 10th percentile for a 25-year-old male, in fact. We also measured his muscle strength and found that he had, compared to people in our laboratory that we had tested, he would have had the predicted leg strength of a 20.5-year-old male on the leg press machinery that we use. So somebody with many chronic illnesses, you would be hard put to say that he had successfully aged, but in fact had been able to do something with all of those conditions. So I think when I think about physical activity, I don't think it as a way to prevent aging or prevent disease even necessarily, but it's a way of dealing with what we come across in light of our genetic predisposition, whatever ecological factors we might be exposed to. It determines, in fact, how our chronic diseases will not only express themselves, but will result in improved or not health status. So I think many of the current studies that we and others are doing are trying to integrate all of these factors when we're looking at how physical activity relates to health and aging. But when we think about what we do about physical activity in reality, the question really comes to mind is, are we really just paying lip service to this idea that exercise is medicine? Or are we really serious about it? And just yesterday, I think the Healthy People 2020 report came out in JAMA, and we got a tick, in fact, for physical activity performance in the U.S. because we meet, in fact, just meet the guidelines for 2020 of 20.6% of the population meeting the physical activity guidelines or goals for both aerobic and muscle strength. So we get a tick for that because we're meeting that. But what that really means when you think about it is that 80% of the population is not meeting those guidelines. So despite congratulating ourselves for meeting this target, I think in fact we are really paying lip service to the idea of trying to integrate exercise into medical care. And I think in some ways, we're doing a disservice to exercise because it really is far more powerful than we give it credit for. So when you think about what a drug is, according to the FDA, a drug means an article that's intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease in man, or intended to affect the structure and function of the body of man, or intended for use as a component of any article specified in those clauses. So in that definition, exercise is clearly a drug, as all of you will know, which means that we should treat it like a drug if we're serious about that. We should define the potential indications. There would be animal studies that predate human trials of safety, efficacy, dose response, and translational research. There would be cost-effectiveness analysis, and all of that would be followed by Medicare and health insurance coverage. So a lot of what you've been seeing in the last couple of days at this ACSM meeting are all of the things in white, in white on this slide. So we do that pretty well, but in fact, we haven't really made that last step to really considering it a drug that we feel like paying for as a nation. And that, I think, is really where we have not really met the bar in terms of what could be done with this drug. So how, in fact, can physical activity prevent or treat disease throughout the lifespan? Well, there are many, many ways, and I can't go through all of them today, but it includes things like optimizing the attainment of peak metabolic and physical fitness and body composition, counteracting age-related changes in physiology, addressing risk factors for chronic disease, affecting the underlying pathophysiology of the disease itself, lessening syndromes of disuse or underuse of various body systems, contributing to better nutritional status, optimizing the psychological profile, and even attenuating the adverse side effects of drugs that we use for various conditions. So all of those things are possible, and you've seen evidence of many of them in this meeting. The physiology is the easiest thing to show. So if you look at these studies of master athletes by Heath, you can see that compared to sedentary individuals, master athletes actually start a bit higher, quite a bit higher in terms of their aerobic capacity. So some of this is genetic and not lifestyle. And although they age at relatively the same rate on average, they still end up quite a bit better. So an 80-year-old looks like a 37-year-old in terms of aerobic capacity on average if they are in this category. But what's more interesting, I think, in Booth's analysis of the training doses is that it really depends what these master athletes do over their lifetime in terms of how they really age. So the ones who continue to train, they decline the least, whereas the ones who stop training, they actually decline even faster than sedentary individuals, so that by the age of 80 again, they actually don't look like they have ever exercised. They've lost not only their genetic predisposition to higher aerobic capacity, but they've lost all of those years of training benefit. So it matters what you do, whether you're habitually active as a master athlete or somebody who was really not genetically endowed in the first place. If you haven't been a master athlete all your life, and if you've just been an ordinary person who then decides at some age to start exercising, does it really matter in terms of physiology? Well, it seems to. This gentleman, who's now 103 years of age, didn't start running until he was 81. He was a farmer, so he was physically active, but not a runner. Did his first marathon at the age of 89 and his last one at the age of nearly 102. And he's somebody who didn't have a lifetime of elite physical activity, certainly, but became quite active in a very old age. And in fact, when his bone mineral density was studied at the age of 99, it was equivalent to a 25 to 35-year-old. So again, there is probably some genetic predisposition here, but as a lot of studies about osteoporosis will show you, it really matters what you do when you're old in terms of your bone density and your risk for hip fracture, as well as what you were born with. So there are lots of diseases in which chronic exercise has a therapeutic effect. I can't go into all of them today, but they range from, as you can see, obesity, cardiometabolic disease, metabolic syndrome and its risk factors, chronic lung disease, stroke, etc. So many, many things that are the bread and butter of the geriatrician, in fact, have been shown in good randomized controlled trials to be positively affected by exercise. But if you really want to know what's important, you have to ask your 4-year-old, as I did when I talked to my daughter Christina in 1988, when I was just beginning my career at Harvard. And I asked her, I was about to give a big lecture to the Harvard academics, and I wanted to impress them with how important exercise was. So I asked my daughter, why should old people exercise? And this is literally what she said to me: because if they don't, they will be as big as a house, and if they do, they will be strong and happy and able to take care of themselves. So Christina thereby wrote my next few NIH grants and actually dictated the next 26 years of my career. She's still an artist, and I'm still doing exactly what she told me to at the age of 4. So I'm going to just go through a few of these conditions, not all of them for lack of time, and talk about how exercise is a drug, both for the prevention and treatment of these conditions as I see it. So in terms of diabetes and its many comorbidities, in terms of prevention, as I'll show you, it's actually better than drugs. Not equivalent to, but better. In terms of a treatment, it is an alternative or additive to drug therapy. So obesity is certainly part of diabetes and its complications, and generalized obesity results in things like loss of self-esteem and self-efficacy, mobility impairment, disability, and osteoarthritis. Visceral obesity in particular has a lot more metabolic complications, which you all are very familiar with, as well as things like cognitive impairment, depression, and sarcopenia even are now linked to visceral obesity. So a very broad range of conditions. As you know, there are 7 or 8 large diabetes prevention trials which have been done, randomized controlled trials showing that lifestyle, both diet and exercise in combination usually, are very effective for preventing the onset of diabetes in these very, very high-risk individuals. And the largest of these was the Diabetes Prevention Program, for which the 10-year follow-up data was recently published. And you can see that in the overall cohort, which started out with about 3,200 individuals, lifestyle was the most effective, and this was very intensive counseling for both diet and exercise over the first 3 years of the study. Was the most effective at preventing incident type 2 diabetes. Metformin was in the middle, and the placebo group, or essentially the usual care group, was given advice to exercise but no structured way to carry it out. So even after 10 years, the group that got lifestyle had the most benefit in terms of reduction in incident diabetes. But what's really interesting, I think, in this study also is that there was a very big age difference in terms of the responsiveness to this intervention. So in the young individuals, metformin actually worked as well as lifestyle. In the middle-aged individuals, 45 to 65, they looked like the overall group, as they were about the largest group in the study. But in the old individuals, in fact, metformin was no better than just advice to take a walk and eat better. And it was the lifestyle group that had a very significant reduction in incident diabetes. So if we're thinking of this as a drug, as most drugs do, what you do to different individuals depends on many things, but certainly age is one of the things that dictates how you prescribe this drug. So would you prescribe metformin to prevent diabetes in an older adult? Based on this data, you wouldn't. And I think that's the important thing, is looking at the intricacies of the data, not just the overall blanket message as we sometimes do. What about if you've already developed type 2 diabetes? Is it worth exercising in that case? Well, this is the most recent systematic review, of the largest one to date, which involved 47 randomized controlled trials, 8,538 patients, all with type 2 diabetes. All of the trials were at least 12 weeks and had hemoglobin A1C as a primary outcome. And they were trials in which there was structured exercise given or advice to exercise with or without diet. But they all had to include exercise as a primary intervention component. And this is what they saw in this meta-analysis. This is the weighted mean difference in hemoglobin A1C, so going down is good. And what you can see is that aerobic exercise, resistance training, combined exercise, all of these structured, supervised exercise, or lifestyle advice, which was again with a large behavioral component, they all worked to a relatively equivalent extent, not statistically different, and to about the same degree that adding a second oral hypoglycemic agent would to metformin. So what you get is about minus 0.67% reduction in hemoglobin A1C if you add a second drug to metformin, as most doctors would be inclined to do. You can get the same benefit by providing structured or highly motivational behavioral advice to exercise with or without diet. Activity advice alone does not work. It results in a very small, statistically insignificant reduction in hemoglobin A1C. So just telling someone to be more active without giving them structured exercise or a way to do it doesn't work, unfortunately. In the largest of these studies of the treatment of type 2 diabetes, the Look-Ahead study, which all of you again would be quite familiar with, involved over 5,000 individuals. The intervention was very similar to the diabetes prevention program, except that there was a bit more physical activity, 175 as opposed to 150 minutes a week. There was an energy-restricted low-fat diet, lots and lots of behavioral intervention weekly for 6 months, so much more than simply a pat on the back. Meant to be gone for 13 and a half years, was actually stopped a few years early because of a futility analysis that showed that the primary outcome was not successful. But what happened in the study was that, if you can see, the weight loss in the blue is the intervention group, 8.6% at 1 year, which is highly efficacious, and still after almost 10 years, 6% weight loss. So that's considered quite good in terms of these kinds of trials. The control group lost about 3.5% over this time. They were just given advice, but no structured way to exercise. And you can see that the benefits parallel each other in terms of waist circumference, glycosylated hemoglobin, and physical fitness going up. And as you see in most of these kinds of lifestyle trials, after that first year or so of intensive behavioral intervention, the benefits begin to wane a bit, but still some benefit even out to 10 years. So many people considered this not a successful trial because the primary outcome was not benefited. There's the same incident cardiovascular disease in both the intervention and the control group. But remember, this was a relatively young group. Only 14% had cardiovascular disease at baseline, so the ability to prevent new events was perhaps not there as much as the investigators thought. But what's really important, I think, is that from many of the other papers that are published from this study, there were highly significant outcomes in lots of other realms, things like incontinence, sleep apnea, depression, quality of life, and physical function. So it was a successful trial. It simply wasn't successful for the cardiovascular primary outcome, but it does suggest that exercise and lifestyle advice works if you do it in a highly structured way. Now, there are lots of different approaches to treating diabetes. This is a different study called the ACTED study, which was done in the UK, where they were much more highly focused on diet. So they had a nutritionist, dietitian talk to the patients 5 times over the course of the year, a nurse 9 times in addition to that. And what you can see what happened is in the diet group, which is in light blue here, they had a reduction in hemoglobin A1C, but it was only, as you can see, about 1/3 as big as can be seen with the structured exercise programs or the structured program of the DPP, which was far more activity-oriented. So even though this worked, focusing more on diet than exercise actually does not seem to be the answer for type 2 diabetes, in my opinion. Inflammation is another very important related outcome in studies of type 2 diabetes. It's important for cardiovascular disease, but it's also important for frailty. As you will know, in these studies of the women's health and aging studies, the risk of frailty is in fact increased 10-fold in women at the highest tertile or quintile of inflammation. So in this ACTED study, which I just showed you, they were also able to reduce the proportion of people who had very elevated CRP levels. And again, they showed that diet and exercise were relatively equivalent. And the take-home message of the authors of this study was, there's not really any benefit to adding exercise to diet. But I think the real message is, if you do it in a way that isn't very aggressive in terms of the exercise, you're probably right. It doesn't really add much. So I think there's probably a different interpretation to this study, and there are quite a few studies showing that even exercise without diet, in fact, can be quite potent if you prescribe it as a drug in a way that is quite robust and structured. In this study of O'Leary, you can see, for example, that 5 hours a week of a relatively robust form of aerobic exercise gets you a reduction in visceral fat. And that reduction in visceral fat is very strongly related to the improvement in insulin resistance in this cohort. So it does work if you prescribe it in a way that we know is effective in terms of its dose. But the real question is, what does it really mean to reduce your hemoglobin A1C by 0.67% or so, the amount you can get from exercise? Well, for that, we have to go to other studies. This is the ADVANCE study looking at what does intensive blood glucose control get you in terms of microvascular complications. So you can see that if you give extra drugs and get the blood glucose down a bit more, you can reduce the hemoglobin A1C from about 7.3 to 6.5%, which is considered very optimal control. And if you look at the microvascular complications, what happens if you do that, what you get is about a 21% reduction in nephropathy and a 14% reduction in the combined outcome of nephropathy and retinopathy. So these kinds of trials are generally not, these kinds of outcomes are generally not done with diabetes and exercise, but extrapolating from these kinds of benefits, that's about what you would get. So is it beneficial to reduce the hemoglobin A1C by 0.2 instead of 0.6 or 0.7? Maybe, but if you really want to benefit your diabetic patient, I think you need to use it at a dose that we know works. So we talked about obesity, but I think the other part of the side of the coin that isn't as well represented perhaps in this literature is the fact that muscle mass and muscle strength also relate to many things, but they do relate to glucose homeostasis and insulin resistance as well. And if you have a combination of aging and inactivity that results in muscle loss as well as fat gain, the two of those things together are in fact the worst possible scenario in terms of metabolism and insulin resistance, and will lead to all of the things we know in terms of metabolic syndrome and ultimately cardiovascular disease. So most of the literature has devoted itself to the obesity side of the coin and the aerobic side of the equation, but I think that we need to look a little bit farther at the other end of the aerobic and resistance to exercise spectrum. So our usual treatment paradigm for type 2 diabetes, I think, is not quite right in terms of lifestyle advice. We usually start with a weight loss diet. The compliance to that is very low outside of clinical trials, as you know. There is muscle and bone loss. If people do happen to follow your advice, you will lose significant amounts of muscle and bone in doing that, and you'll also decrease your metabolic rate. So diet alone is really not the answer. What about adding aerobic exercise? Well, that does work, and it's good if you can do it. But if you think about your typical patient with a BMI of 33, osteoarthritis of the knees, peripheral vascular disease, cardiovascular disease, how many of them can actually do the kinds of exercise that you read about in these clinical trials? Most of these clinical trials have in fact excluded people with cardiovascular disease and severe osteoarthritis. So even though it works, it may not in fact be applicable to your particular patient. So because neither of these things work very well, we very quickly go to drugs, which results in lots of polypharmacy and iatrogenesis, weight gain, in fact, from most of the drugs, as well as insulin, as you know, and most importantly, no treatment of the underlying causes of the visceral obesity and inactivity. And that's, I think, the most important point. So we need a bit better of a paradigm. And one question I think needs to be asked is anabolic exercise a rational or viable alternative for people who can't do the kinds of aerobic exercise that you see represented in these trials? What would be the rationale? Well, we're trying to get people to go from metabolic syndrome to metabolic fitness. You'll notice this does not look like Ray Moon over here. This looks like somebody who's just a bit fitter than the average person with diabetes. You're going from catabolism to anabolism in terms of the hormones and the cytokines. And what that shift in body composition and anabolism will give you is muscle gain and fat loss. So sometimes the overall body weight, in fact, doesn't change. You gain a kilo or two of muscle, you lose a kilo or two of fat. But underlying that apparent lack of body weight change are a whole host of changes in metabolism and function that are in fact quite beneficial. So we can see this in the 2 or 3 trials that have been done of weightlifting exercise. It's still a very small literature, weightlifting exercise for older diabetics. In this study, the Great To Do study, in which we're still doing the ongoing 6-year follow-up, what we saw was that, in fact, in this study, which was high-intensity power training versus sham weightlifting exercise, in which people sit on the machines and lift a very low percentage of their 1RM, 20 to 30%, without altering that over the course of the year, but they think they're exercising. What we saw was that intramuscular lipid index, or how much fat there is inside of the muscle in the thigh, was related to the hemoglobin A1C change. So those people who gained fat inside their muscle had a worse hemoglobin A1C at the end of the year. And that happened in the exercise group. But in the control group, in fact, there was no relationship. So it only mattered that you were able to reduce your intramuscular fat if you were doing it via exercise, and in this case, high-intensity power training. And we saw the exact same thing for insulin resistance, fasting insulin resistance by HOMA, that individuals who increased their muscle mass improved their insulin resistance, and individuals who decreased their body fat improved their insulin resistance. But again, those changes were only seen in the people who were doing the high-intensity power training, and there was no relationship in people who shifted their body composition without exercise. So it seems to matter not only how your body composition changes in terms of direction, but how you got to those changes. And just losing weight, in fact, was not beneficial in this particular cohort for these outcomes. Some of the other things that we and others have been looking at in terms of diabetic comorbidities would be peripheral vascular disease. And I think this peripheral vascular disease is a disease in which exercise has an extremely primary role. And in fact, as you'll see in this meta-analysis of 47 trials comparing surgery, angioplasty, and exercise, really deserves to be at the forefront of our treatment of this condition. So this is a study of 47 trials, over 3,000 individuals, looking at absolute claudication distance and quality of life as the outcomes. And what they saw was that whether people had surgery, angioplasty, or structured supervised exercise, these are not statistically different from each other. They all got very large benefits in terms of absolute claudication distance. So you can see the effect sizes here are all over 1.5. They're very large compared to the kinds of effect sizes we normally see. The one thing that did not work, in fact, was non-supervised exercise. So it was not actually significantly different than the usual care control. So this is a disease in which if you give exercise, you need to do it in a structured, supervised way, it appears, in order for it to be beneficial. Same thing was seen for improvement in physical quality of life. So it's really important to know if you can send somebody to a surgeon or to an exercise physiologist and get exactly the same outcome for peripheral vascular disease, which one would you do? And which one would your patient rather have done? So I think looking at exercise really as a drug, or in this case as a surgical alternative, is very, very important for trying to incorporate it really more directly into our healthcare system. So how do you get structured exercise to be done? Well, we thought one way to cleverly do it in the healthcare setting was to actually integrate it directly into the rest of their medical care. So if you're unlucky and you have diabetes for long enough, you may go on to develop end-stage renal disease and end up on dialysis. And you might think, well, there's no hope there. What's the point of exercising if you already have no kidneys and you're hooked up to a dialysis machine? Well, we thought, well, this is a perfect opportunity for supervised structured exercise because the audience is captive. They're coming for their dialysis session 3 or 4 days a week in Australia, in fact. And this is a good opportunity to try and show that exercise is really part of medical care. So we did a study where we had them lift weights in the midst of the dialysis sessions, towards the middle of their session when they were not completely dried out but still able to exercise quite well. We exercised, this can show here, we exercised them, see if I can get this to play. The arm that was about to be hooked up to the dialysis machine was exercised first. It's going to work. Sorry. Well, you'll have to imagine him lifting this weight. So the arm that was about to be hooked up to the dialysis machine exercised first, and then after that fistula was hooked up, the rest of the body was exercised, and we were able to do the legs. So really a whole body training regimen over about 45 minutes in the course of their 3 to 4 hour dialysis session. And in the series of publications from this study, we were able to improve muscle strength, physical function, CT scan measures of muscle size, as well as some aspects of quality of life. So many of the things that go wrong with dialysis in terms of sarcopenia, wasting, depression, etc., are able to be addressed by inserting exercise right into the middle of the dialysis session itself. And what about if you are lucky enough to actually get out of your dialysis session and get a new organ? Are you then free of the need to exercise? Well, from very old studies that were done by Randy Braith and a few others, we can see that this is in fact a perfect time to add exercise to the equation. So if you have a congestive heart failure and you get a brand new heart, say you're 50 years old and you get a brand new 25-year-old heart, you put that in your body, what happens over 6 months is that you lose 10 years worth of muscle mass in 6 months. Why? because we prescribed you prednisone as well as giving you a brand new heart. So you probably weren't very good in the beginning because you'd been unable to exercise for quite a few years because of your heart failure, and now we've aged you another 10 years in terms of your musculoskeletal system in only 6 months. So if you continue, I'm sorry, this is only 3 months. If you continue another 3 months along this trajectory, you will lose, despite your brand new heart, more and more of this muscle mass. But what happens if you, at this point, add high-intensity progressive resistance training to your prednisone, and you give both prescriptions to this patient? Well, they end up actually overcoming the effects of prednisone and actually gaining half a decade or so worth of muscle mass than compared to where they started. So they're vastly different than the people without exercise, and they're even better than they were before they got the prednisone. So there are now lots of studies in the literature suggesting that if you give anybody prednisone for any indication, that you must oppose that catabolic influence with an anabolic exercise. Walking won't do it. It requires an anabolic exercise to oppose the catabolism. So again, thinking about exercise like a drug and thinking about altering the side effects of various drugs that we give, this is one of the most important indications. So you might think, well, everybody must be doing this, right? Every transplant service in the world must have a gym attached where they're giving weightlifting exercise. Well, I don't know of one. I don't know if anybody in the audience does, but this, in fact, is not being done. Yet the literature, as you can see, is quite old, 1998, and many, many things would benefit if we change that. What about frailty and mobility disability? Well, here, I think, is where the evidence really comes out in favor of exercise. For both prevention and treatment, clearly exercise is better than drugs. So many people have worked for many years to develop a drug to treat frailty or to treat sarcopenia. It hasn't worked. The drug companies are constantly looking for something that would be as good as exercise, and they haven't found it. And I think what we should be doing is saying, well, we know what the answer is. So we know that if you're Albert Beckles and you just do this for most of your life, you in fact can age quite well. You will not become frail. He's actually 84 now. He still works out at Muscle Beach. I saw him a couple of years ago in California. He looks a little bit different than he did at 62, but not dramatically different. So there is a way to actually alter the trajectory of frailty that we see otherwise in many patients. You can do it if you're Jack LaLanne, who was still lifting weights at age 96 until his cardiologist told him to stop, and he promptly died about 6 months later. You can start at the age of 71 and look like this at the age of 75 if you like, or you can perhaps not start until you're 90, as little Annie Nyman did here in one of our studies. But there is a role for anabolic exercise as well as aerobic exercise, I think, in frailty. And it depends what kind of frailty you're talking about. So not all frailty is alike. Frailty can be quite different. One of the most important reasons for mobility impairment and disability is osteoarthritis of the knee, as you will know. So there are a lot of trials about arthritis and exercise focusing on mobility as an outcome and trying to change things like the ground reaction forces at the knee, particularly the knee adduction moment. The IDEA study is one of the most recent ones from Messier and colleagues, which was just published last year, showing that a very intense structured exercise program consisting of aerobic exercise, resistance training, as well as a weight loss diet had a significant impact on, in this case, the WOMAC score, as well as many other outcomes, compared to diet alone or exercise alone. So in this case, where you've got overweight individuals who have knee arthritis, clearly the treatment for their mobility impairment is to try and address both of those things together, which is better than doing one or the other alone. So very important for arthritis studies. We're doing a study now to try and refine the prescription even a little bit more called the LOW study, where again we're looking at knee adduction moment as the primary outcome in older overweight individuals with knee OA. It's a 1-year randomized controlled trial. We have 5 different groups and we're trying various combinations to see the isolated and independent effects of diet, weightlifting exercise, gait retraining, all 3 together, and a lifestyle control arm. Now the diet we're using is similar to the Diogenes study, is a low GI, high protein diet, because you can see that's the only diet in this study that actually successfully sustained weight loss compared to all different versions of low fat, low protein, high GI, etc. So this is a very good diet for diabetes. It also turns out to be a very good diet for osteoarthritis. It is anti-inflammatory, sustainable, and results in a clear, steady weight loss. Why weightlifting exercise? Well, because it helps all of the structures around the knee, and also because it will prevent muscle and bone loss from a weight loss diet, which you would otherwise get. And gait retraining is a relatively new modality in which you alter the way the person actually walks in terms of either trunk sway or turning the toe out, which actually markedly diminishes the forces at the knee. So our theory in this trial is that all three would probably be the best way to treat this condition, because it isn't a simple problem. It's a very complicated problem, and simple solutions probably don't work. But certainly patting somebody on the back and telling them to take a walk is not going to be the answer to severe knee arthritis in an overweight, obese adult. In some individuals who are obese and frail, have what we call sarcopenic obesity, but not necessarily arthritis. Other kinds of combinations are effective. So, for example, in the study of Villarreal, combination of a low-calorie diet, aerobic resistance and balance training was very effective for weight loss as well as other outcomes in this older population. So you need to know what's causing the frailty before deciding how to treat it. And as you would have heard on Tuesday from Marco Pahor in the very successful LIFE study that was just published, looking at older individuals who are not necessarily needing to lose weight, but have incident risk for mobility impairment, you can reduce that risk of incident mobility, in this case by about 28%, by giving people relatively moderate exercise, but relatively structured and intense behavioral counseling to increase their aerobic exercise, their resistance training exercise, compared to a health education group. So you do need to do more than just tell people about exercise for it to work. As Steve mentioned, one of the earlier studies we did was on very old individuals looking at frailty in a different cohort who were not overweight and obese. In fact, they were nursing home residents who tended to be undernourished. In this study, we showed that the combination now of a nutritional supplement plus weightlifting exercise was the best treatment for their muscle weakness and frailty. And in fact, not only did strength improve, but when we looked at muscle biopsies in these 90 to 100-year-old thighs, what we saw was the emergence of myoblasts and myotubes, and evidence of real regeneration of muscle tissue from satellite cells, even in these people in the 10th decade of life. So there really is no age at which anybody has shown that it's impossible to adapt to appropriate kinds of exercise. So over the last 26 years, the kinds of things that we've been able to show, and other people in many, many laboratories around the world have shown, is that you can improve all of those things we talked about in the first slide in terms of physiology, many kinds of diseases, mobility, diabetes, wasting, even prevention of type 2 diabetes, because several of the diabetes prevention programs actually included resistance training in their treatment. And there is epidemiological evidence now that you can actually prevent metabolic syndrome and cardiovascular disease from large prospective cohort studies with resistance training exercise, independent of any aerobic training or exercise habits. So a very large evidence base now for this kind of exercise. What about depression? One of the first things Christina said is that old people will be happy if they exercise, and she turns out to be right in that case as well. Again, from Healthy People 2020 rather, we're not doing that well in terms of depression. Suicide rates are up. Adolescent depression is up. So there is a need to both prevent and treat depressive illness. For prevention, exercise is the treatment. There is no drug that prevents depression. And for treatment, exercise, in fact, is one of the most important treatments for this condition, recognized now by the American Psychiatric Association, although not by other organizations. It is at least equivalent to, if not better than, drugs. So there has been a lot of study in this in younger adults. In older adults, we did the first study in 1997, rather, where we had older adults with clinical depression lift weights, and we saw that compared to an education group, the weightlifting group had a significant improvement in their depression scores by 4 or 5 different indices that we used. And then when we withdrew supervision at 10 weeks, in fact, the effect did not go away as it does in some other kinds of trials. In fact, they continued to get better over 10 weeks in addition, even without any supervision. So as you know, depression tends to remit, so even in the controls they get better, but there's a very significant difference at 20 weeks of weightlifting exercise. We then didn't follow these people except for one phone call at 26 months to see what had gone on with them. And when we followed them up, we found that in the people who had originally been prescribed exercise, almost all of them were still in remission. People who were in the control group, many of them had relapsed, and the people who had been originally exercising but stopped, they looked like they had never started. So this looks like those master athletes, doesn't it? If you do it, it works. If you stop it, it doesn't work. But it's a very potent treatment, in fact, for depression. And to show that a little bit more definitively, we did a trial in Australia looking at comparing GP care of depression, which is the standard way that depression is treated in Australia, to 2 different doses of weightlifting exercise, high-intensity weightlifting exercise or low-intensity weightlifting exercise. The only difference between these 2 groups, they did exactly the same exercises on exactly the same machines with exactly the same trainers, but at 30% rather than 80% of the 1RM. And what we see is a clear dose-response effect, and in fact, the low-intensity weightlifting was no different than the GP care group, and in fact, the 30% reductions or so that they got is equivalent to what you get with a placebo. So GP care is like a placebo, low-intensity weightlifting is like a placebo, high-intensity weightlifting is like the best antidepressant drug we have on the market today. In fact, a little bit better. So why aren't psychiatrists using this? We don't know, but I think it's because, again, exercise is not really being seen as a drug, but for depression, it's one of the most clear-cut indications for using it as a drug. We did see that the higher they got in terms of muscle strength, the better they got in terms of their depression reduction. So it seems like there is a dose-response effect, and there is a threshold at which exercise of this type does not work. And one very interesting finding we saw was that we measured what was called outcome expectancy, which is whether or not people believed that the weightlifting exercise was going to help them. In the high-intensity group, it didn't matter what they believed. If they thought it was going to work, they didn't think it was going to work, they all benefited for the most part. In the low-intensity group, people who thought it was going to work, it worked. And people who didn't think it was going to work, it didn't work. So very much like a placebo. So another indication that, in fact, exercise is working like a drug. It's working in a physiological way. It's not about gathering people into a room, making them feel better, making them socialize. It's actually working on the brain like a drug. And I think that's really the important message from these kinds of studies. What about osteoporosis? This is actually why I got into geriatrics in the first place, is because my grandmother fell and broke her hip when I was in high school and didn't do well at all. But for osteoporosis, prevention is clearly in the realm of exercise and diet rather than drugs. For treatment, exercise is clearly additive to drugs. It's not a replacement for bisphosphonates. It's not nearly as potent in terms of bone density as bisphosphonates are, but it has something which is quite different and necessary to add, as I'll show you. So in children, high-impact exercise is the best way to go, as most of you would know. As you get older, what you do depends on what's actually wrong with them in terms of their bones. So at middle age, what aerobic and strength training, and particularly aerobic exercise that is relatively higher in impact, like jogging, tends to be what works in clinical trials. In older adults, what seems to be most beneficial is weightlifting and balance exercise for the protection of the bone. So over the course of the lifespan, what you do matters very much on who you're treating with this indication. Well, this is what the NIH put out a few years ago about osteoporosis and exercise. I don't know why. Hopefully nobody in this room is responsible for this photo, but this doesn't really work for anything. I'm not sure what they're doing here, but it certainly isn't something for their bones as advertised, or their balance, and it isn't what we recommend because it isn't what the evidence base would show us is effective. Can exercise prevent osteoporotic fracture? There's only one study that has ever shown that that's the case, and it's a study by Sanaki. After 10 years, women who got back extension exercises with a relatively low load, 30% of their back extensor strength, progressing over a couple of years. When she saw them 10 years later, they had a significant reduction in vertebral fractures compared to the controls who got no intervention. But this is the only study so far that has shown that exercise can actually prevent fracture. Most of that is due to the fact that most exercise studies are only 1 year long and involve very small numbers of individuals. Most of the drug trials in osteoporosis are many years long and involve many thousands of individuals. So we really don't have the data yet, except from this study, to show that exercise itself can prevent fracture. But the other thing about fracture is that it's not really just about the bone. If you look at this risk for osteoporosis study from relatively recently, what you can see is that of people who fractured their hip, only about 26% of individuals with hip fracture actually had an osteoporotic bone density score. So a lot of people who fracture their hip actually have normal bone density. Well, you might ask, how can that be? And the reason is that there are a lot of things that cause hip fracture. And what does hip fracture look like? Well, it really depends who you are. What it looks like to you will depend on who you are, and what you see is what you will treat. So if you're an endocrinologist, you're going to treat bone density. If you're an exercise physiologist, you might be treating something quite different. If you're a psychologist or a geriatrician or a nutritionist, again, you'll be treating something quite different. And I think the problem with hip fracture is we haven't really figured out what is essential to treat and how to treat it. But when I think about hip fracture, I think of it as a condition characterized by frailty, compromised musculoskeletal composition and strength, predisposing to a risk of fracture and falls. And what hip fracture looks like then is not simply low bone density, but it's all those structures around the bone, like the muscle and the mobility, that will in fact predispose this person to fall or not fall. In a study we did called SHIP, we looked to see what happened to disability after hip fracture, and we used the NHANES Disability Index of 23 different tasks and how difficult they were. If you go higher on this score, you're worse. So if we look at the blue, that's what they look like at baseline. In red is what they look like at 4 months, and in yellow is what they look like at 12 months. And like all prospective cohort studies about hip fracture, where you are at 4 months after your hip fracture is about where you're going to be 12 months later, not any better. So this is after 4 months of relatively intensive, if you will, physiotherapy and rehab in orthogeriatric units, etc. We're not doing very well. People are worse 4 months later than they were before they fractured their hip. Only 20% are even back to baseline at 4 months. 80% are worse. So what is it that's causing all this disability? Lots of different things. Most of the studies on hip fracture rehabilitation have been negative, as you see, even though meta-analyses have sometimes pulled out a significant effect combining all these different types of rehab, etc. Most studies have not really been able to budge this. So we looked at the literature and what we saw in SHIP as well as the rest of the literature to see, well, what were all the things that were wrong with these people that could potentially be fixed to try and make them better. So everything from sarcopenia, muscle weakness, poor balance, malnutrition, cognitive impairment, depression, osteoporosis itself, vitamin D deficiency, low self-efficacy, fear of falling, polypharmacy, physical inactivity, inadequate social support. Those are all of the things in the literature that people have found that are potentially treatable, but are mostly not treated by the orthopedic surgeons looking at the broken bone. So being a geriatrician, we designed a study called HipFit, which had 13 different intervention arms. Why 13? Because those were the 13 treatable things causing disability post-hip fracture. Some of them everybody got because they needed them, so high-intensity weightlifting, balance training, home safety evaluations and hip protectors, calcium and self-efficacy. Other things were only given if they needed them based on our targets, so things like treatment of malnutrition, polypharmacy, visual vitamin D, visual impairment, depression, cognitive impairment, social support. But you can see by the numbers of people who needed things, most people needed 10 out of these 13 interventions. So it's not hard to imagine why trials of a single intervention after hip fracture have been unsuccessful, because most people actually needed 10 things corrected. So what happens if you do this kind of a study, if you treat all of the things that people need after hip fracture? Well, we gave them, as I say, high-intensity weightlifting exercise. The way we usually do it, we gave them high-intensity progressive balance training, both static and dynamic, all of it under supervision for a year, 2 days a week. And then we gave them all those other things that I mentioned. And when we looked at our primary outcome, which was poor outcome in hip fracture, which is defined as nursing home residence or death at 1 year, what we saw is that we were able to reduce these outcomes by over 80%, 82 to 85%, death, nursing home admission, and poor outcome. And this was the first study to ever show this. And I think the reason it showed it is that we weren't trying to be efficient, if you will, in terms of, or selective in terms of what we treated. We were trying to treat everything that we thought they needed. So it's not easy to do this kind of a study, but it actually is possible. And it's also not rocket science. It's exactly what my grandmother would have told me she needed when she fell and broke her hip at the age of 85, because those were all the things that were wrong with her. We also followed them up for 5 years, and you can see that even though we stopped the intervention at 1 year, at 2 years we still had a 64% reduction in nursing home residence or death even a year after stopping our intervention. And that, as you might expect, would go away, always still a little bit lower in the intervention group, but going away gradually over 5 years, when most of these individuals were in their mid to late 90s. So looking at why they improved, there were several things we saw that were related to the improvement. Improvement in IADL status, habitual gait speed, maximal gait speed, 6-minute walk distance, and functional status, nutritional status rather. All of these things improved at 12 months and predicted the beneficial outcomes in terms of nursing home residence and death at 1 year. So still looking at some of the intricacies of this, but do seem to be able to move this outcome. So I think that in terms of trying to do this, to reduce long-term morbidity and mortality after hip fracture requires a real paradigm shift in terms of how we treat this condition, to modify the frailty components themselves, in particular sarcopenia and malnutrition, rather than focusing on the broken bone, because that's really not the problem with hip fracture. Maybe we need to rename the condition. And I'll end up with cognitive impairment now as the final thing to talk about. In here, prevention, certainly exercise as well as other risk factor modification to prevent stroke, et cetera, is the way to go. For treatment, I think it's still a little bit of a question mark. There isn't a good drug for treating it. Exercise works in some cases, but not in others. This is a meta-analysis we just did in mild cognitive impairment, showing that there's really no significant benefit. There's lots of studies on both sides of the line. No overall consensus that exercise works, despite what you read in the lay press. There are lots and lots of negative studies about the treatment of cognition with exercise. However, there is lots of theory to support using it. We do know that hippocampal volume goes down with age, BDNF goes down with age. Those things are thought to lead to memory impairment. And we know, in fact, that exercise is good at modifying those things. So, for example, higher hippocampal volume has been related to higher cardiorespiratory fitness in cross-sectional studies, as well as to aerobic exercise interventions in randomized controlled trials. In addition, larger prefrontal and temporal cortex volumes have been seen in people who walk more in these aerobic exercise studies by Erickson and others. And even in a more recent study, even Tai Chi now has been shown to actually increase brain volume to the same extent, in fact, as an intellectual discussion group did in their particular study, whereas walking in a control group were not effective in this Chinese cohort. So we don't know the full answer yet, but we do know that the brain is relatively plastic, even at an old age, and we need to know a little bit more about what kind of intervention works best. So Tai Chi, again, improved cognition, whereas it was worse in the control subjects in this study, but walking, again, for these Chinese individuals was not a successful intervention. Exercise is related to these changes. Exercise can modify BDNF, it can modify hippocampal volume, and as I've shown you, it relates to depression. So these are all theoretical models of how it might all fit together, but we certainly don't have all the answers yet. We've just completed the first phase of a 5-year study on exercise and cognition called SMART, which was a trial of cognitive training but with multi-domain cognitive training versus progressive resistance training versus both conditions or a control group. And again, lots of different pathways we hypothesize might be helpful for improving cognitive function in this study. This was a study of older adults who already had mild cognitive impairment but not dementia, 6 months of supervised training with an 18-month follow-up, and then a 5-year follow-up for cognition and function. The 4 arms you see here, high-intensity PRT or sham cognitive training, computerized cognitive training, or sham exercise, which was calisthenics, both active interventions, or the double sham control. So it was double-blind in terms of the outcomes. Primary outcome was ADAS-Cog, which is used in all of the drug trials for MCI and dementia as a primary outcome. And we've just finished analyzing the primary outcomes of the study at 6 and 18 months. And what we saw was that there was a significant improvement in ADAS-Cog in those who got PRT versus those who didn't, whereas cognitive training, there was no differential benefit in terms of with or without cognitive training. But this was our primary outcome, and over 40% of people at the end had normal cognitive function on the ADAS-Cog compared to only 25% at the beginning of the trial. So a very significant effect in terms of the resistance training. And very interestingly enough, and very counter to our hypotheses, the combined training was in fact worse than the individual training. So PRT worked very well. Cognitive training was not significantly different than control. The combined group was significantly worse than the PRT. Now, this is a little bit hard to describe and understand, but there are studies where combined, for example, aerobic and resistance training are not as good as either intervention alone. It's possible that in some way this was more stressful than just one or the other. So we really don't know the answer yet. We haven't analyzed all of the secondary outcomes, but we do see that resistance training had a very significant effect on cognition so far. So just to summarize then, if you remember what I said in the beginning, there are lots of different ways that exercise can be used as medicine. I've only talked about a few of them, but I think that the potential is there if we will consider it to be a drug. So what is the prescription? Is it drinking red wine, as this 104-year-old gentleman in Sardinia is doing, or is it something else? Or is it, as Maya Angelou said, simply living with passion and compassion? One answer is iron. Take as much as you can carry without causing pain. Lift as far as you can about 24 times. Repeat 2 to 3 days a week for life. But that's only one answer. You also need to add aerobic exercise and balance exercise appropriate to the mobility status and the conditions that you're trying to treat. You can be a master athlete like Ruth Firth. Most of us will not see people like her or in our practices, but there is evidence that you can, in fact, avert many things about aging with attention to physical activity. But I think that our mission really is not to make master athletes of anyone or everyone, but as Walter Bortz would say, the mission of medicine is the assertion and the assurance of the human potential, whatever potential that is. Thank you.